This conference will now be recorded.
Good evening, everybody. It is the 6th of January 2025. Happy New Year to all our AnCanners. I hope this year will bring much good health or the best health possible for everybody listening and attending. And I should add, I think, just seeing Eric leave, I should add this is the high risk recurrent advanced group, in case anybody was wondering. And if anybody and everybody is welcome to attend, but you should at least know which group it is because we don't want to freak you out. I want to thank the sponsors, Bayer, Novartis, Johnson and Johnson, Telix, Myriad, Blue Earth, and somebody else. Who did I miss, Captain? Oh, oh, don't tell me you're not backing me up, Captain. Who did I miss?
Well,
Foundation medicine.
Thank you, Foundation Medicine. Thank you very much. Um, so there's a couple of things that are on my mind. The first two things are old chestnuts. We have 409 responses when I looked earlier on today on the survey. I don't know how many are prostate, but my guess is around 60%. It may even be higher. I got to talk to Miss Alexa tomorrow and find that out because she's been really watching the numbers. It's enough for us to get rolling, and we're reaching out in different areas. I'm working with Dr. John. We've got 4 or 5 people lined up for analysis, and we may find some corporate players for analysis too. Guess the second thing is, if you read the reminder, I've actually been in touch with Novartis about responses to that Pluvicto ad and told them what's going on, for which they're very grateful. And they may be interested in doing something with us on the impact of the support group. There's also a huge grant proposal from Pfizer on how to educate HCPs on advanced prostate cancer, which follows up on our whole treatment intensification thing that we've been speaking about. The fact that AUA, Education and Research, is sponsoring this with Pfizer probably means we won't get anywhere because they don't like me personally, and they really don't pay much attention to give much credence to patient support and patient advocacy, and it's really focused at institutions. And I've reached out to 2 or 3 different institutions to ask them if they'd be interested in partnering with us. But if you're following this thread that we're having in the reminder, 43% of men who are metastatic hormone sensitive do not receive more than Lupron, which is scary. And I would say that the number of men who don't receive more than Lupron in this group who are metastatic hormone sensitive, that's clearly metastatic hormone sensitive, is probably less than 5% and may even be 0%. There's a couple of tricky situations where there's some nodes on recurrence and the docs don't want to prescribe, but it's not because the patients haven't asked or pushed for it. But if that's what a support group can do, take that 43% number down to 0%, I think we're doing a great job. Now, on that score, we are doing a great job because Dr. John headed up a little team that wrote a letter to JAMA about that 43% number, and the letter got published. And so if you go back to the reminder from right before Christmas Eve, you'll find the link, or I'll be putting it in next week. You'll have to forgive me. I just don't have time. Maybe Dr. John can put it in right now. I don't have time to look at it whilst I'm leading the moderation this week. And at the top, it says comment. And if you click on comment, you'll see a whole bunch of names that are going to be very familiar to you. And a lot of people gave Dr. John a bunch of feedback, and he penned a magnificent letter, though I say it myself. And it basically says, this is really atrocious, that there is this lack of treatment intensification, and we need to do much better, and we need to see, and we need more GU med-oncs involved. That said, this grant I was referring to, which is sponsored by AUA, they're not huge fans of GU med-oncs. What a surprise. So I don't know where we'll go. All right, that's a lot. That's a bunch of time that I took just now, about 8 minutes. I just want to check with Wes because he was here before the 10 after, and we lost him. Wes, hello. Back.
New.
Wes,
Back.
are you?
So,
Wes, are you new?
I'm brand new.
That's what I thought. Okay, well, we'll try it. We will make.
I have intraductal. I see urologist on Wednesday. I'm just opening doors. Got the link from a buddy who.
Okay, we'll make time for you towards the end of this first hour, but we're going to have to move pretty quickly because we've got a lot of people that need time. All right, we're kicking off here with Gary Newell. So Gary, let me do a quick intake. How old are you, Mr. Newell?
71.
Okay, and where do you live?
Reston, Virginia.
Oh, you got snow too.
A lot.
And what year were you first diagnosed?
This year, or I'm sorry, 2024.
Okay.
Around about October.
Okay. And what was your Gleason score and your PSA at the time of diagnosis?
Gleason score, I don't know. And it may be sort of a factor of a function of how this came to be diagnosed. My primary care.
What was your PSA? We'll get to that in a second. What was your PSA?
It was 800 something, 818.
Got it. Okay. So, and what doctor were you seeing at the time of diagnosis and which institution?
I was seeing my primary care physician, Dr. Cooper, who's with the Herndon Family Medicine practice, which is part of Inova.
Okay, and so where did he first send you? To Inova?
He sent me to Shar. Yeah.
He sent you to Shar. Okay. So we're going to say Shar. And who are you seeing at Shar?
The practitioner I'm seeing at Shar is Dr. It's an easy name to remember if you like football. Jason Allen.
Oh, so you're saying, okay, we know Jason Allen. Okay. Now, when they saw this, tell us how you were, how were you diagnosed? What made your doc decide to do a PSA?
we do a regular 6-month medications update visit, frequently virtual, but usually in person. Part of that is a series of blood tests, including a basic metabolic panel that includes alkaline phosphatase readings. For the first time, the test that was taken in, I think it was August, showed an alkaline phosphatase level that was elevated.
Right.
So he subsequently sent me to another blood sample was taken to do a differentiated analysis between bone and liver. It was determined to be bone related. At that point, he sent me for a CT that was focused on identifying hotspots, identified a number of hotspots,
Okay.
mostly in the bone. At that time, there didn't appear to be lymph node involvement, but there was plenty of bone lesions, shoulder, rib cage in the back, and a few other places.
Okay.
He then referred me to Dr. Allen, and I don't have the sequence of events.
Okay.
But
Let me interrupt you for a second, in the interest of time. When was this PSA done? After you got to Dr. Allen or before you got to Dr. Allen?
no, it was before. I think it was once the alkaline phosphatase level was determined to be bone related.
Okay. And when was the last time you had a PSA before this year?
I don't even know.
Okay.
Dr. Cooper was of a mind that apparently there were two schools of thought, or at least two.
Yeah.
On it.
Don't get me started. We're not going there.
Okay.
But it makes me mad, and I'd love to talk to Dr. Cooper myself, because it's because of doctors like Dr. Cooper, and I had a doctor like Dr. Cooper, by the way, Gary. So I have the T-shirt, and my disease should never have gotten as far as it did. It wasn't as exaggerated as yours, but it is criminal. It's because of Dr. Cooper that we're losing men. It's because of Dr. Cooper that we've got somewhere around a 15 to 20% de novo metastatic diagnosis. And hopefully, next time you see Dr. Cooper, if you're staying with him, you'll say to him, would you now please test every man? Because nobody should have to go through what I'm going through. It makes me mad. We said this would happen back in 2012. We wrote to USPSTF. We said, this is what it's going to be. And I already knew it. How did I know it? Because it happened to me in 2007, because I had an idiot doctor. He was a good doctor, but he had stupid ideas on PSA. And this is a perfect example of why PSA, here's what you can mention to Dr. Cooper. PSA is about information, not treatment. PSA is about information, not treatment. Because when doctors think that PSA is about treatment, which is why they don't prescribe it, it's because they themselves are not doing their job. So I got it. I got the picture.
It's worse than that even, but I won't necessarily.
Yeah. Well, I got the picture. So you had a CT scan. You went to see Dr. Allen, and what did Dr. Allen prescribe?
Well, the regimen I'm on right now is a 3-pronged regimen. I guess it's kind of standard, but it was written down. What do I do with it? Anyways, it's here we go. Eligard once every 3 months. Nubeqa, which is darolutamide. I think that's 600 milligrams twice a day. And 6 administrations of docetaxel.
Okay. How many lesions in total do you know showed up in the CT scan, roughly?
I don't know because the reports said things like a number of and several, and so I don't know a precise number. It may be in the report that
Yeah,
went to the doctor.
ask for a copy of those reports. You should have them in your file if for any reason you need to switch. How many sessions of docetaxel have you done so far?
I had my 3rd today.
Okay. That's why you're so alert. You're on that Dex high, man.
You bet.
I know. We got it.
Good stuff for 2 days.
Yeah. Right, Mr. Valens, you know about that, right, sir? So, are you on a bone strengthener? Is he giving you anything like any type of denosumab, Prolia or Xgeva or anything like that?
No,
Has it been discussed with you?
a bone strengthener. No,
Well,
other than he suggested I take a calcium supplement.
yeah, well, I'm surprised because he's not bad, Alan, but he should be prescribing you with your situation something like Prolia. And next time you see him, or send him, don't even wait till next time, send him a note. Dr. Allen, is there any reason why you're not giving me prescribing me a bone strengthener?
I
Okay.
think that's a good idea. I do have osteopenia already.
Yeah, definitely. Has he done any type of genetic or genomic testing?
He connected me with the company that does that for patients at SHAR, and I did have the full analysis, the full panel done. There were no indicators of a genetic component.
Okay. And I'm assuming that was based on either a blood sample or a bone sample.
A blood sample.
Okay. Now, are you sure that that was for all your mutations, or was it only for anything you might have inherited? Or you don't know?
I don't know for certain. I would guess inherited.
Okay, so you should also be getting a somatic test, which is anything you've made yourself. And that is actually required now by the guidelines. So again, you can mention to Dr. Allen, you understand that somatic test is in order and you would like a somatic test. Do you have any cancer in your family, Gary?
Not that I know of.
Okay. So I still think that you need, I definitely think that you need a somatic test. It's in the guidelines. We need to know if you are a good candidate for any specific types of treatment. Plus, it's a very good baseline to have at the beginning of your treatment. So please ask him for a somatic test.
That's looking for mutations that are not inherited.
Exactly. Correct. Exactly. Mutations that you have made yourself in your own body.
Okay.
Okay. Now, the other discussion, but it can probably wait, but put it on your agenda is at some time you should discuss with them about debulking the primary tumor with radiation.
We did discuss that today. He's planning to connect me with, he offered to connect me earlier, but the idea would be to do some of that after the chemotherapy is completed.
Okay.
So that's on
As
his
long
radar.
as it's on his radar, that I think that works. That works absolutely fine. And did you receive a reminder for this meeting, or did you just join? Did you just join us?
I did receive a reminder by email. I think Jim Marshall may have
Yes.
set me up for this group. Jim? Yeah.
Yes, he did set you up, and you're all good, and you're in the database. Right. That completes my questions. We're going to take just 10 minutes to have a discussion. I also know Joe Commander had his hand up when I was doing the introduction. Joe, is it something relatively quick that we can deal with?
Let's leave it pass, and it'll come up again. Don't worry about it.
All
It's
right.
not.
Or next meeting, take time. Okay.
Yeah.
Make a note.
Okay.
And next meeting, take time for what you want to bring up. Is that
Okay.
okay?
Yeah, that's great. Yeah. Thank you.
Okay. I'm throwing it out, and Jeff Marchi has something to say.
But you want to definitely ask your doctor what your Gleason score is and get that number. It's very important.
Well,
It's
yeah, he
something-
didn't have a biopsy, Jeff.
Oh, he didn't? Oh,
I didn't have a prostate biopsy.
Right.
I had a bone biopsy
Right.
that
okay.
identified the cancer cells as prostate as the source. So I don't know whether a Gleason score
No,
requires a prostate biopsy or not.
that's a great question, but I've never heard a Gleason score be associated with a metastatic lesion. Has anybody else ever heard of a Gleason score associated with a metastatic lesion? That would be a great question to ask Epstein or Zhao or somebody else. But I don't think they do. They only read Gleason scores from the gland. My feeling is that's because once it gets to a distant location, it's going to show up as a 4 or a 5. It's already going to be so advanced. What would you say, Len?
I do not know, Rick. I have also never heard of a metastatic lesion being characterized by Gleason score.
Yeah, Mark Valens, do you have something on that one?
Well, just that I had metastasis to my adrenal gland, and they tested that, and the Gleason went up to 10 when they did that. It was 5+4 on the original one.
Yeah. I think it's because as part of its ability to metastasize and move, it does take on the format of the most aggressive type of prostate cancer. Otherwise, it couldn't get to where it's going. And so I would suspect that any metastasis is probably going to show a 5+5. I think that's what we would learn, but we'll ask. We'll definitely check that one out. Okay, Wes, save what you got, and I'll be coming to you, and you can raise it when we talk to you directly. Let's see. Anything else that I have missed that we should be talking to Gary Newell about, other than, and I know we haven't done it, other than exercise and diet and all that good stuff?
Any scans?
Well, there was a CT scan, but that's a good point, Dr. John. Did you have did your lesion show up on a PSMA scan, Gary? Gary? Did we lose? Oh, you're there. Unmute.
There we go.
Yes,
Now you can hear me.
yes.
Yeah, after the first CT scan, Dr. Allen ordered a PSMA, and lots of lesions showed up.
Okay. So again, please get copies of all of your reports for your files. Digital copies, whatever you like. You never know when you might need them.
So Gary, nothing in the liver then on your PSMA scan, right? Just bones?
It did in the PSMA start to show up in lymph nodes. The first,
Lymph nodes?
yeah, the first CT scan did not indicate lymph node involvement, but the PSMA did. But there was nothing in the liver or kidneys or elsewhere.
Okay. Any questions you have for us, Gary? There's a lot of knowledge in this room.
Yeah, at this time I'm probably too ignorant to ask an intelligent question, so I'll save it for a subsequent session. But you've given me a lot.
How are you feeling right now, Gary?
How am I feeling?
Yeah, how are you feeling? Do you have any pain anywhere? You sleeping okay? Are you?
Surprisingly, I feel pretty good.
Good.
I've tolerated the docetaxel pretty well, at least, to date. No nausea or vomiting, just some heartburn, and a spike in pain about 3 days after the infusion. I'll get a spike in back and leg pain for about 4 to 5 days, and then that will resolve.
And how did you happen to have osteopenia? It's not that common in a male.
I don't know. I don't know whether it's whether there's a genetic component to that or not, because my mother had osteoporosis. But at some point, as I say, about 10 years ago, I got a bone scan, and it did show some osteopenia. It showed a thinning of the neck of the femur.
Okay. Well, you'll want to follow that closely and probably get on some medication.
Well, that's the medication that we're suggesting, Gary.
Yeah.
Okay.
It's the same medication, and I would actually tend to disagree with Dr. John. I think it's a lot more common in men than we know. I was diagnosed osteopenic, osteoporotic at age 56. I never checked, and we tend not to check men, and we think it's not that common because we don't check them. But I think if we checked them, we'd find it a lot more common. It's part of the routine treatment for women as they enter menopause, but we don't check men, and I think that we should check men. But that's exactly why we're recommending that you get the bone strength. No, okay. I do want to move on because we've got a lot of people, and we got to intake Wes. I did just put in the chat window. I see Dr. John did put something earlier, but this is the specific link to the article. And if you at the top of that article, if you click on comment, you'll find our letter. It takes you all the way there, as Dr. John says. Okay, Mr. Pollock, what is on your mind regarding Gary?
I was just wondering if he was doing anything for neuropathy to kind of ease it off some.
Not so far. As I say, today was my third infusion. I have been using ice mitts and booties.
Oh, good for
during the
you.
infusions. So that may have helped, but so far no neuropathy, thank goodness.
Okay, so you're getting this every 3 weeks, correct?
Yes,
And so this was your third, so you started 6 weeks ago. Did you have hair before 6 weeks ago or not?
I had beautiful hair. I looked like Steve Martin. I was frequently mistaken for Steve Martin.
I see. Okay. Okay. Just want to know. Jimmy Greenfield.
There's just one more thing. There's one more medicine that we strongly suggest for your osteopenia if it hasn't been discussed. I had to be away for a moment. And that is weightlifting, especially for your legs. Weightlifting, weight training.
Oh,
Do you do any of that?
no.
I strongly suggest, especially if you're getting on testosterone suppressants and you already have osteopenia, it's pretty much, it is anyway, but it's really, really, really important.
Just check with the docs on that because it's just possible that one of those bone mets is in a vulnerable spot. So just double check first.
Yeah. So we do know that if you start to feel significant side effects, actually well before, that exercise is really important during chemo, as counterintuitive as it is. Talk to Dr. Allen about exercise. Ask to see somebody at Inova Shar about nutrition and diet, and hopefully ask to see somebody about exercise if they have somebody there. And if you don't get any information, come back here. And when one of these days, when we ask you, do you need time? You say, yes, I'd like to talk about exercise, and we will get into it. It's just a little much, and we tend to sort of skirt it at an intake because there's enough other things. So I'm going to make an executive decision to move on. Frank, can we hear you at this point?
Yeah, I think so.
Yes, we can. Did you need time tonight?
No, I'm just listening in. I'm good. Thank you very much.
Okay. All right, Wes, you have the picture, and so if you don't mind, I'll ask you a few questions. So, how old are you?
72. Tell me if
Okay.
my headphones are feedbacking.
No, we're good. We'll let you know if they are, for sure. And where do you live, Wes?
San Diego.
Ah, okay. We like San Diego. And did you say you've just been diagnosed or you've just progressed?
Last month.
Diagnosed.
Correct.
Okay.
MRI in November because my PSA had elevated. I was on testosterone supplements.
Okay. So what was, at the time that they diagnosed you, what was your Gleason score and what was your PSA?
So the PSA had been 3 and 4 while I was on supplements the last couple of years. It went to 5.5 and 6.5. That prompted the MRI. 2 locations were identified. They did the biopsy last month. Those were positive with AnCan, or however you pronounce it. 2 of them were intraductal. I had the biopsy like the 20th of December. That came back with the biopsy came back with 2 intraductal, like 7 AnCan, a Gleason score of 7.
Okay.
And what I was going to comment on is the intraductal did not give a Gleason score, perhaps because it's defined as aggressive.
Okay. Now, do you have metastasis?
I don't know. I talked to the urologist in 2 days to determine what all to do.
Okay. The reason I'm asking is because this group is for high risk, recurrent, and advanced. Now, the intraductal probably pushes you into that high risk group. Was it a 4+3 or a 3+4?
Both.
So
I
you had
had
four.
I had a couple 6s, and I had a 7 that was 4-3 and a 7 that was 3-4. Of note, my father had prostate cancer diagnosed at 72. It was removed. My grandfather, biologic grandfather, died of prostate cancer at 83.
Okay.
One of my questions is just
Yes.
to meet the group, but what to do to identify the best thing, you know, a PET scan, a CT scan, a bone scan,
Okay.
what I
So
have in my
let, let,
pocket
let,
to
let
identify
me
things.
ask you a couple more questions and then we'll get to that and we'll give you the best navigation we can. Is that okay?
Super.
Where are you being treated?
At Scripps Institute, Scripps Health.
Scripps Health. Are you married to Scripps Health?
I've had been there for 40 years. I have a guy named Kanajetti that I think is quite good.
Okay. Spell his name for me, please.
Konigeti. Indian.
Carnegie. Okay. And he's a urologist.
He's a urologist, but he specializes in prostate surgery.
Yeah, a urological oncologist. He's a surgeon.
Correct.
The reason I ask is because Scripps is fine. We happen to think UCSD is a heck of a lot better. They've got some really good people at UCSD, and especially if you're dealing with intraductal, which is a lot more complicated. Have you had your slides reread?
No, and I was at UCSD for testosterone supplement, but that guy would have had to refer me to somebody else, the
Yes,
urologist.
yes, that's not his field. But overall, and we know some good urologists at UCSD. We've had people with advanced disease who have been treated by them, so we have some names. But
Excellent.
have your slides been reread?
They have been read and confirmed by within the same world,
Right.
and they've been
So
stained.
what we would suggest, the first thing we would definitely suggest is you send those slides out, and you send them to Dr. Ming Zhu at Mount Sinai. And if you call Scripps, and we'd like to see that intraductal get confirmed by one of the docs we consider to have the very best eye in the country, maybe even the world. I mean, he and Dr. Epstein, and Dr. Epstein's just coming back into play right now. He's not reading slides just yet, but Zhu was trained by Epstein. He was at Johns Hopkins, and then he was at Tufts, and he now heads up the group at Mount Sinai. So somebody hopefully can put Ming Zhu's information in the chat window for you. If not, I'll do it when I get a second to for a break. But I think
I
that
believe that was in the email that I used, but thank you. Yes.
yes, I mean, definitely in a situation where it could be high risk because if you're not introductory, you're not even high risk. Then you're definitely
Correct.
intermediate. So
No, if it weren't introductal, I would have a different attitude.
right. So we want to confirm that introductal outside of Scripps.
Okay.
And the way I would suggest we do that is by sending those slides to Ming Zhu. He's really good. Tell him you're an AnCanner. He'll call you up and speak to you directly.
Okay.
That's his training from Dr. Epstein, who does that with everybody, and he's learned that, and he does it. I don't know if we've had any guys in here who have spoken to him, but it happens. It really happens. He calls you up, and he's a very good guy. You can see if you search for him on our website, you can find a
No, I got
webinar we did with him. So
we'll take the whoopsies. All right, so got the good. Thanks, guys.
So if you're going to see Dr. Coneghetti very soon, if it were me, I would be saying to him, I do want to get the intraductal confirmed for sure.
Okay.
Where were these lesions? Were they close to the edge of the prostate? Were they in the base of the prostate? Where were they?
That I do not know. The biopsy. I also had paraneural in 2 locations, but the
Right.
locations other than general locations on the prostate, I don't know. So I don't know how invasive it is, metastatic, etc.
Well,
I was told that I would meet with urologist, oncologist, hormone guy in a group. That may not occur Wednesday, but I expect it would occur soon.
okay. Do you have a copy of your biopsy report?
I do.
Okay. If you look in that biopsy report, you should find exactly where those lesions were located. They will state it somewhere in the biopsy report. If they don't, we got a problem in the quality of the report.
When you say lesion, that's not a word that I'm familiar with. There were biopsy sample sites. There were 2 locations identified on the MRI that were areas of interest.
Right.
Those were sampled 2 each. Then there were
Okay.
10 Easter egg
And
sites.
did they find prostate cancer in those 2 locations?
2 of the samples in 1 location tested positive. 1 of the samples was benign, and the
Okay,
second
so
location
those are
was negative.
lesions. Those are
Those are
lesions,
lesions. Okay.
right?
Those
Those
were
are
identified and confirmed.
sites of prostate cancer. Those are, you can call them tumor, you can call them a lesion, or whatever else.
Okay.
And oh, look, Dr. John and Mark Valens have put a bunch of information in there for you in the chat window about for Mingzhu. Thanks, gents. So we
And I
need to
have
know.
the biopsy up in front of me. I can read it, but it doesn't say things that mean much to me.
Okay, does it say which quadrants they were found in?
101 cores, approximately 5% of core, high grade prostate epithelial. No.
Okay, well, ask rather than take the time in the group, because we've got a lot of people that need time today.
Right.
Ask Dr. Coneghetti to where exactly they were, and you can come back either to us, or I would also recommend you sign up. Are you signed up with us?
No, I just barely got on the website relatively inefficiently,
Oh,
but I'll go through all the hoops. One of my buddies who had prostate cancer pointed me to you with an email, so I just showed up, and I
okay.
appreciate
Well, that's
the time.
fine. No, you don't. It's free drop in. That's absolutely fine. But if you put your email address in the chat window, and if you don't want to put it to everybody, just send it to me, and then I'll make sure you get on the list for the reminders going forward. And probably the best meeting for you to attend is this time next week, which is the low intermediate. And you know, and even though I know you have introductory, there's knowledge in there, I'll probably be in that group, and then you can come and see us the next day if you want to. That's great. Thanks, Wes. So I'm trying to think, is there anything else you need? Yes. You definitely need to ask Dr. Coneghetti, if he hasn't done so yet, to do a germline test. Has he done that yet?
We haven't done anything but the biopsy.
Okay. So we will put in the chat window a link for you where you can get a free germline test.
Okay.
With color. But he should run that germline test himself based on what you told us about prostate cancer in the family.
And And germline, so put it in the chat because that doesn't make sense to me what it
Yeah,
is.
I understand. Bye, Adam. Thanks for stopping by. Germline means inherited, and it means you may have inherited a mutation that could affect your treatment. And so
Excellent.
we're gonna test you to see if you inherited anything.
Well, that would
All
be
right?
important to my 63-year-old brother.
It would, definitely. Well, let me just say, your 63-year-old brother should go and get himself tested, get his PSA tested right away, because your diagnosis already puts him behind the 8 ball.
Right, his
So
PSA is 0.5, but intraductal doesn't raise PSA from what I've learned.
right, intraductal is different, but as long as he's monitoring it, and then we can decide what he does next based on you.
So you're doing great, and I'm consuming time, so I do appreciate the timeliness of your answers.
Okay, so here's the link for the promise test. You can click on this and here's the link for the promise test. My cursor's not behaving. There we go. There's the link for the promise test. I just put it in. It's done with color. It's an okay test, but the panel is only 32, and we're actually finding some people with mutations that are important that color doesn't test for, but you know, you get what you pay for, and for a 32 gene test, it's fine. But I would suggest Dr. Conaghetti gets the test. Anything else anybody wants to suggest to Wes to ask his Dr. Conaghetti for tomorrow?
Yes, the cribriform, a decipher test. He's a perfect case to get as a decipher test to find out how aggressively his cancer could come back if he's treated.
Good suggestion.
And the other thing is that intraductal, that seminar we went to, almost always means cribriform. So he should have them investigate those slides a little bit more closely for cribriform, because they claim that they always find cribriform when there's intraductal.
Okay,
and they did note that.
Oh, they did
Didn't know
note
what it meant,
cribriform.
Yeah, they didn't. I don't know what it meant, but
All right,
yes,
well,
that's
that means your 4+3 is much more aggressive than a 4+3. And you want to find out if it's larger than 0.25 millimeters, because if it's larger than 0.25 millimeters, it is more aggressive.
got it.
So the decipher test and find out about that cribriform.
Okay, and get a second view on those slides to confirm there's agreement that it is intraductal and it is cribriform.
So one question, gentlemen, I would have thought before I talked to you guys that I would have just gone to Conaghetti. I would have said, okay, we need a prostate removal. You're going to do that. You're going to do the lymph nodes, and then we're going to do some other tests to find out where else in my body it is. But that seems a little premature based on what I've heard the last hour.
Well, to respond to that very quickly, first of all, I wouldn't necessarily recommend surgery. And that's why you need to attend the low intermediate group. You need to hear the pros and cons of surgery versus radiation, because you could also do it with radiation. For men over 70, surgery ain't great. Now, there are a lot more surgeons willing to do it now, but it's a very, very tough process. And I don't want to get into a discussion in this group of surgery versus radiation, but we will definitely take you through that in detail in the low intermediate group. Secondly, yes, you may be a good candidate for a PSMA scan. Based on the intraductal, you can discuss it, but I would want to get that intraductal confirmed before I ask for the PSMA scan. because
Okay.
it's an expensive, not to you, but it's an expensive procedure. It's getting used more often than it should be. And what we're looking for in there is for disease outside of the prostate. And it is a very effective way. And if you have intraductal and cribriform, you are a good candidate for PSMA, for a PSMA scan.
Okay. Good. Thank you.
Okay. So with that, I really want to move along.
And Rick, there's also the non-radiation, non-surgery things like HIFU,
Yeah,
cryoablation,
we're not going to get
nanolite
into that, Jeff. We're
ultrasound.
not going to get into that here. It's not appropriate. That's why we do it in the low intermediate. Come to the next
Okay.
low intermediate, and you can go through all of those treatment choices with Wes. Okay,
Yeah.
this is not a group to talk about treatment for
He should
initial.
know there are other choices. That's the thing that are not radiation or surgery, and they're quite
Okay.
effective
Sounds
as
good.
well, and allow you to do radiation and surgery after. So
There is absolutely no space in a 4+3 for any of the treatments that Jeff Marchi is talking about. Those are all focal treatments. And we strongly oppose focal treatments. This is why it bothers me, because people talk when they don't have the bloody knowledge. And we should be discussing that in a different group. All of those treatments that Jeff mentioned are focal treatments. Focal treatments are not appropriate for anybody with a 4+3. They may be appropriate for somebody with a 3+4. Okay,
Okay.
let's
Sounds
move on.
good. Thank you.
Pleasure. All right, Gaoshan, you're up first. Gaoshan, are you there? All right, we'll come back to Gaoshan.
Yeah, I'm here now.
Okay.
Okay, so I recently picked up my PSA test results, and my PSA now is 0.063. So it's above what OHSU says is undetectable. And my previous thoughts were that certainly it's not appropriate at this time to have a PSMA scan, but because the last time I did a PSMA scan way back in 2020, it took 4 or 5 months to get it arranged and approved. So I already contacted the doctor, but I was thinking you needed a score of 0.25 to 0.5, but Rick sent me some data from a Dr. Amicho that says, no, you should do it at 0.15 and no later than 0.25. So I sent an update to my doctor to arrange my next appointment appropriately, and I'll be doing my PSA test again in March and in May just to move it up to watch where it's at. So it has climbed up. The previous test was 0.03, so it went up a bit. But as Rick said, when it's still low and undetectable, the things are not 100% accurate and can jump around, which indeed is the case. So I'm just going to keep watching my PSA and see where it gets in March and May, and if it gets close to 0.1, then I will take action.
Anybody want to comment or say anything to Gaoshan? Where are you, Gaoshan? In Shanghai?
Yep, I'm in Shanghai, but I leave to go back to Panama in mid-February.
Okay. Anybody have anything anything to say?
I think that all makes good sense, Kaushan. we're starting to worry at, you know, 0.15 and want to get a scan by about 0.2 now.
Right.
So, yeah, keep an
Yeah,
eye.
Rick sent me those links because my previous thoughts was like at 0.25 to 0.5, which new testing and research is done. You need to do it earlier, so I appreciate
Yeah.
that.
I've been arguing about this same thing with my oncology team as well. I mean, there's even some evidence that PET scans can show recurrence before the PSA even bumps up at all. So I agree with what you're doing.
Right. And my previous PSMA PET scan that was in October of 2020 showed no results. I mean, found nothing. Even though the cancer was there, it was just invisible or not gone into any lesions.
Okay.
Thank you.
I'm keeping an eye on the time. And then Dr. John said he doesn't need to raise it today, but he's got my curiosity. So I want to get through this quickly enough so that we can find out what he's got on his mind. Kang, go ahead, please.
Hi. Yeah, thanks. My case is my PSC has been climbing, rising, and the PSMA and the FDG scan cannot pick up anything. My doctor seems to suggest me to go for the random clinical trial. And the second opinion I got from MSK, the doctor seems to have the same idea. As far as going for more tests, to find out what is behind the PSC rising, but imaging cannot pick it up. I can't seem to get any answer. That's my case. That's where I am now. I have a question for Rick. When you mentioned about, I understand next generation sequencing. I know it's tough to get it. I've been pushing it. I don't think they're gonna do a repeat for me. And Dr. McHugh seems to say the same thing. He said, "Well, I only visited him once. That was for the second opinion." He said, "Well, if you don't get it when you're two, when your PS is two, you probably won't be get it when it's five. It's like the two doctors basically has the same opinion. It's like your PSA has to really go up in order for you to pick up. I don't know that for sure. That's what I got."
Well, I mean, the answer is what we've seen is your PSA has to be over 4 if you have fairly normal disease. So there's a good chance you'll get it at 5. This is why I'm suggesting they do a ctDNA scan or a ctDNA test or a CTC test, because we want to see the extent of your disease burden, because everybody's
Is
guessing on how much disease you have.
is ctDNA blood draw or
Yes.
it is blood draw? Does it belong to the NGS, next generation sequencing?
Kinda. So they can do a next generation sequencing based on the DNA that is circulating in your blood. So if we know you've got a lot of DNA circulating in your blood, it also tells us that we're likely to get a result if we do a blood draw for a next generation sequencing. Same thing with the circulating tumor cells. If we find whole cells, the difference, as I understand it, between circulating tumor cells and ctDNA is ctDNA are these little fraction snips that break off the tumor, and CTC, circulating tumor cells, are whole cells that break off the tumor. And we can capture either or. But the ability to just capture the DNA means we can find the cancer earlier. And so one of the proposed uses for ctDNA is to determine, is a treatment working? Not so much in prostate cancer, but in other cancers. So as you're going through treatment, so somebody like Gary Newell, who has done 3 docetaxels, or Mark Valance, who's done 2 docetaxels, we can be testing their ctDNA and determine how effective the treatment has been.
Okay, that's if the treatment starts, I can still do the CTC or ctDNA test with
Yeah,
the
but
blood.
we don't need it for that. We need it now to see what's going on and if there's how much disease there is in your body.
If that too, like ctDNA or CTC test, doesn't go through the Tempus or foundation, can the hospital, can the institution themselves do it?
There are a number of labs that do it. Signatera is the one that comes to mind, but there are a number of labs that do it. I can't tell you if Tempus does it. I suspect Tempus probably does. What do you call it? Does not. Foundation Medicine doesn't, but Signatera does. And just Google and look who does. Google who tests for ctDNA. But Signatera is the one that's been getting a lot of research published and making the space. Whoops, I sent that to Jeff Marchi alone, and I didn't mean to do that, so I'll send it to everybody. Paste everyone. And I have a link for them, but I can't really look for it right now, I'm afraid, Kang. But look for Signatera. Read a little bit about it, and it was me. I mean, Len, what you've been working with Kang as I have. I mean, do you think a CTC or a ctDNA, since we've got no idea what's going on with him, we can't find it anywhere?
Yeah, sure. Any information we can get could be helpful to Kang, because the scans don't seem to be giving us much information. And even before you begin treatment, whatever the treatment is, it might be good to get a baseline on what your CTC count is or your ctDNA count is, so you can see if the therapy is working, if it's being effective.
Yeah, I don't think the doctors will do that, right? I mean,
well, you got to advocate.
They don't do.
You got to advocate for it. You've got to ask them, why are they treating you? And if they say, well, we're treating you because your PSA has gone from 1 to 5 and we can't find out where it is, you say, I want to know that I've got this disease in my body.
Okay.
And you've got to argue for it. I mean, when they say no, you don't say, okay. You say, no, I want this. And you put it in writing. Have you put it in writing in the portal? I want a CTC test, or I want a ctDNA test? Or have you said, do you think I should get one?
I actually did for the next generation sequencing. I put it on a portal. The answer was doctor doesn't advise a repeat soon. Next generation sequencing soon.
Okay. Okay. Then have you asked for a CTC test?
That I didn't yet, but I'm going to.
So you ask for a CTC test, ask for a ctDNA test in both places, and tell them I would like a ctDNA or a CTC test, please.
Okay.
Because I don't know where the cancer is. You want to treat me. I want to make sure there's cancer in my bloodstream.
All right. Okay. That's a reasonable request. Is it?
Right.
Is it?
So, yeah, okay. Kang, I can't get into it in detail, man. There's a lot of people here.
Okay. All right. Okay.
But I think that you can ask them for that. And if they say no, you say, then I want to talk to the doctor. But I want a CTC test. Tell them, what if I've just got BPH? Well, you couldn't have, you don't have a prostate, so you couldn't have BPH. But, we don't have enough information. What else is on your mind?
Next thing is, before I had the SBRT in year 2021, there was a biopsy. There were 2 tissues there. That was summer of 2021. Does that tissue still good for somatic test?
It's good for testing, but I personally wouldn't use it because your disease has moved to a whole different level at this point in time.
Okay.
So you're not going to get a reliable result from testing tissue that's 4 years old, 3 years old.
Okay. That's it. Yeah. Well, quickly, very last question. If I guess, Mount Sinai. Okay. Well, that's okay. I'm done. Thanks.
Okay. Keep working with Len and,
All right.
we'll get you, but you've got to insist and demand for that ctDNA, CTC. Len's argument is perfect. We don't want to just rely on PSA. We want to know how much disease is in your body. If you can't see anything else, let's at least get a ctDNA test before you start any type of therapy.
Yeah, the thing is, time is not on the patient side. Sometimes, like you try to push for an answer, and you just have to take a no for the answer. It's
Kang, there
become
was a
time.
recent publication that found that tracking CTCs is an effective way to monitor the effectiveness of treatment. I'll see if I can find it and I'll send it to you and you can show it to your doctor.
Thank you. I really appreciate that, Lynn.
Yeah, I mean, and it's especially true when we can't see it anywhere else. That's why we suggested it to you. If we could see it somewhere, we could see how it changes, but we can't see it anywhere else. Does anybody else have any suggestions to Kang as to how should advocate to his doctors, either at MSKCC or at Mount Sinai, as to how to get better testing?
Like if gentlemen, anyone who is in the same situation like I am now, so that experience will be valuable.
It's unusual. We don't see disease progressing the way yours has without it showing up somewhere and having more evidence of it. And it doesn't make sense that at 5 you don't have, nothing shows on a PSMA, nothing shows on an FDG PET. So we got to move on.
Right. Yep.
But keep
Thank
talking to Len, and Len, if Len can find that paper, and we got to keep the pressure on these people to give you more information. We don't have enough information. They're bobbing for apples when they treat you at this point in time, in our view.
That's true. Thanks,
Okay.
Rick. Thanks,
Mr. Valens, why don't you update people on how you've been going through the ringer?
Well, the last 12 days have been even worse than the 2 weeks before that, but I'm finally getting a bit better. I found out that I have rare Staphylococcus aureus and Enterobacter homiaceae and spinal compression and low blood pressure. And so I was supposed to get my 3rd chemo last week, but they said I was in terrible shape. But it's strong enough that they think they can go forward with the 3rd one on Thursday. But there are some new things to me. I get up and pee every 2 hours all night long, and then all of a sudden I get up twice to pee, and then the 3rd time I wake up, I've already peed. I never got the message to get up, and they think it's the metastasis on my spine may be compressing the spinal cord. So trying to figure what to do about that. I'm extremely weak. It's 12 steps to the bathroom, and when I get there, I have to sit down to rest. And coming upstairs takes me at least 2 stops in one flight of stairs. So I haven't been getting any exercise for a couple months. I get out of breath totally. Looks like Jimmy left his gym. I was wondering if he had any suggestions how I might get any kind of exercise.
Well, Mark, I mean, when you talk about having this level of fatigue, it takes me back to Dr. Herb, God rest his soul, where he complained of this type of fatigue and nobody checked him again for small cell. And then Dr. Munster said to me, it's obvious when they have this sort of fatigue and they can't get out of the chair, you got to look for small cell. Well, they teach us that in medical school.
I think Mark did that, Rick. I think Mark got
Hold
some
on,
kind of a
hold
recent report that there was no
hold on,
neuroendocrine.
Yes,
hold on.
but there were some neuroendocrine-like cells, is what Dr. Shao said. And so
Oh, that's weird.
I'm getting another PSMA test on Thursday, and then Dr. Shao wants to talk to me after I get that.
Okay, so I hadn't heard that news. So Dr. Shao reread your slides and said there were neuroendocrine-like. Have you reported that to Dr. Agarwal?
I'm not sure.
It is hugely important. Hugely important. I mean, when did you get this news from Dr. Shao?
It was just about a month ago after my
Okay, well, here's what you told me. You said Zhu reports adrenal nodes negative for small cell.
Yes. And I don't really quite know what he means. He said there is no neuroendocrine, but there's neuroendocrine-like. And so that's confusing.
Okay, well, he did say there's endocrine-like.
Yes.
Okay, you didn't. All you told me was there was adrenal node negative for small cell. But if it's endocrine-like, if it's neuroendocrine-like, that's just as important. That's exactly what we're looking for. Okay, so as we've suspected all along, you have neuroendocrine. You have small cell neuroendocrine-like disease, and that changes the chemo that you should be getting. That's why we were looking for it before. So you got to talk to Dr. Agarwal. You got to have Dr. Agarwal talk to your lady. What's her name? I always forget.
Dr. Sam. Dr.
Right.
Sander.
Dr. Shanda. And is she recovered from her RSV yet or not?
She didn't. No, she didn't get. Oh, no, Dr. Sander didn't get RSV. My wife.
Oh, okay. So you've got to, Dr. Shanda, if she knows that you have neuroendocrine-like.
Well, Dr. Shao was not real clear on that. He said there's no neuroendocrine, but I can't remember the word he used. It has aspects that are neuroendocrine-like. He didn't say I have neuroendocrine-like.
All right. So,
and I don't know how you tell the difference.
You're not supposed to know. We talk about this as neuroendocrine, small cell or neuroendocrine-like disease. That's how we phrase it. That's the phrase I always use, small cell or neuroendocrine-like disease. Now, if you've got neuroendocrine-like disease, send those slides that he looked at to Dr. Agarwal for him to take a look at, because he's the expert and he's going to be able to see. So we really have to get these to him. It sounds to me like you've got neuroendocrine disease, and this is why, if you recall, Dr. Agarwal said you got to get an FDG PET, and then we've got to compare it to the PSMA PET. Remember?
Yep. That's in the plan, but I was so sick I didn't get in for some of the scan.
So I want you tell him, Rick pulled me over the coals last night because I let him know that Dr. Zhu thinks we might have neuroendocrine-like cells, and Rick wants you to take a look and see.
Okay.
Did Dr. Shao send you a report, or is this all verbal?
It was all verbal.
I'm almost certain that Dr. Zhao would be willing to talk to Rahul, Dr. Rahul.
I'm sure he would.
Okay? Because I know both of them, and both of them really care. And if you tell Rahul that Zhao thinks you've got neuroendocrine-like, we can put them in touch with each other, and let's find out, because we may need to adjust that chemo.
Yeah. Dr. Shao was, he was waiting to get more information. So he was waiting for me to get the FDG.
Yeah, but we can't be waiting. Yeah, we can't be waiting anymore, or we got to get it done immediately, because there's only a short window to get at this neuroendocrine, and I've been looking for it for the last 2 months, as you know, or 3 months. And I promised myself I wouldn't let this happen to anybody else after what happened with Herbie. And I don't want to see you go the way of Herbie when we've got a chance to treat you. I mean, this is urgent.
Yep. Well, I've been working on it, but I was so sick they didn't even want me to come into the hospital.
No, I get you. But we need that better diagnosis, and between Zhao and Agarwal we can get it, and then we can adjust your treatment. Or
Okay.
there may be a trial that Rahul wants you to go into right away.
I'll learn a lot more on Thursday when I see Dr. Sanders, because she's been pushing to get the FDG and some other ones, and I don't know why it's taking so long.
Yeah, but you won't learn a lot more, because if Dr. Shanda has known that you've got something that could be neuroendocrine, she should have been on it. I mean, you hear how
Dr. Shao never sent any reports.
But he told you. But he told you. And I
didn't record it. I didn't record it. So, and my brain is so screwed up, I'm not sure exactly what he said.
Okay. But as far as I know, Dr. John, we haven't done any other testing. Did you do chromogranin?
Yes.
And did it?
It's okay.
Your chromogranin was good.
Yeah.
Somatostatin?
What's that?
It's another one of these tests to see if you might have neuroendocrine-like disease.
I hadn't heard of that one. Okay.
All right, but please get Zhao and Dr. Agarwal connected as soon as you can.
Yes. It's just the last 2 days that I've been able to get out of bed.
Okay.
Without anything. So, thank you, Rick. I'm doing the best I can.
Yeah, I know. But I just want to be ahead of the game. I want to be a step ahead and not a step behind.
You're welcome to keep pushing.
Okay. All right. Anybody else have anything they want to say to Mark?
Only that we got your back, Mark, and we hope you feel a little better. It must really suck to be so weak.
Yep.
I want to get a commode chair before you fall and break something.
Yep.
If you're having a hard time making it 12 steps to the bathroom,
yeah,
get a commode chair before you break something.
Yep.
And then you'll really be in a world of hurt.
I am getting stronger, so I'm getting around better than I was. Well, thank you, everybody.
I'll give you a buzz, Mark, hopefully tomorrow. Norm Pollock, since that was your voice, you have
Well,
the floor.
sometimes I feel guilty. I've been off ADT since April and just had my PSA, and it's still undetectable. And I'm doing a couple cords of wood a week and getting stronger all the time and feeling better. Well, I hadn't been around for a while, but kind of anticlimactic with everybody else.
Yeah, but we like that.
Yeah, I know. So do I, but it's kind of like, he's just bragging.
Well, that's great.
So you're telling me that for Mr. Pollock, everything in Tennessee is status quo. Is that right?
Other than the ice today, I got to get a shoulder, so I wore out a shoulder, so I'm getting a shoulder in April. But yeah, I drove around in the ice today. It was fun. So
okay, well, don't you fall on that shoulder on the ice. That would not not be smart. Okay?
I was driving on it, not walking on it. So
okay. So we have a couple of people who have gotten shoulders in our group, and if you want to talk to them, we'd be happy to connect you if you let us know. Just give us a shout. Shoulders are not as easy as hips. I just want to tell you.
They're not as easy as hips?
No. Recovering from a shoulder is not as easy a recovery as recovering from a hip is.
No. Well, thanks for that. I've heard it was easier, but yeah.
No, it's not.
Yeah. Well, which one? The reverse? I don't have to have the reverse. I get the anatomical. So.
I think either way, but we know people that have done the reverse, and we know people who have done the anatomical. So I'm just saying. Anybody here got a new shoulder?
No.
Okay.
I've looked into it, but they've told me it's a lot worse than the hip. And that I got over really quick.
Well, I did both hips already too, so.
I had surgery for just a bone spur in the shoulder, and it was very painful for, about a month, I would say, afterwards.
Yeah, the hips were no joy, that's for sure. But
I had rotator cuff surgery, and it was just miserable, absolutely miserable recovery.
Yeah. Thanks, I like that. Well, I don't have to worry till April. So.
Aren't you glad you came, Norm?
Yeah, really. I should have stayed off because they're telling me it's easier. I don't know.
No, it isn't. It isn't. And if you want to talk to people who have done them, just send me a note and I'll connect you.
Okay.
I'm trying to think. Somebody recently I know had a reverse. Oh, Jim Schrate. Jim Schrate. Yeah, I mean, we could talk to Jim Schrate. He's one of our moderators for active surveillance and low intermediate. He's on the board of Zero. And just give me a shout, and I give you his email address, but he never reads his AnCan email address. So you'll send it to him, and then I'll say, Jim, did you talk to our buddy Norm? And he'll say, I didn't see anything. I said, Jim, you're not reading your AnCan email. And
like I told the doc today, when I turned 70, I had this big spot just above my right knee that felt really good and didn't have any pain like the rest of my body. Was there anything he could do with that?
All right, one last question. How's your wife?
Up and down. Yeah, it's progressing.
It is progressing, huh?
Oh yeah, they all progress. So has her good days and her bad days. So.
Okay. Well, I hope to goodness that we can get that. Guys, this is an appeal to everybody and anyone who's listening. We really want to start a care partner group for people that have neuro and mobility care partners for people that live with neuro and mobility conditions. And Norm's wife has PD, but it would include PD, it would include MS, it would include people that have had a stroke, care partners for those people. And we need, Norm has very kindly volunteered. Our Alexa Jet is a second moderator. We need a third moderator to get going. So if you know anybody who is a care partner for somebody with one of those conditions and would be willing to work with us to start a new group for people like Norm and people like Alexa. Alexa's fiance is hemiplegic. Please put them in touch with us because we really want to give support to these people. They need it. It's tough.
That's why I mentioned to Mark to get the commode chair, because she fell a couple of times going to the bathroom at night, and she does yoga, so she's pretty good at falling. She hasn't hurt herself yet, but yeah, Mark, you don't want to break a shoulder or a hip, or then it's not worth it if you're having a hard time getting to the bathroom there.
Absolutely. All right, we're going to keep moving unless anybody else wants to say anything to Mr. Pollock in Tennessee. Guess not. Okay. Next on my list is Doug.
Well, I've managed to move my appointments up one notch, but I didn't go all the way, I'm afraid. Last week I had an appointment and I thought I was going to be able to get referred to the genitourinary oncologist, but I just got referred to a survivorship doctor, urologist. So hopefully I'll get my referral from them for the actual oncologist.
Okay, but when they refer you, are they going to refer you to the oncologist, the medical
Julie Graff?
oncologist? Oh, they're going to refer you to Julie Graff. Okay.
Well,
good.
that's the goal, but it'll be someone. I'll get referred toward her. I don't know what will happen. I'm not going to have the ability to specify a name, but it'll be somebody closely associated with her, I believe.
Okay. And when's that next appointment?
March 4th.
Oh, that's a long way off. When was the last time you did a PSA scan?
End of November, and my next one is due end of January. I have a quick question for you that actually gives me a little bit of comfort. I have a graph. See if I can get it to show. Not doing too well.
Tell me the question.
Has to do with how PSA responds after the combination of radiation and ADT.
Okay.
What this graph is showing is that it's normal to level out somewhere below 1, up near 0.1. Sorry, no, up near 1. But the longer you're on ADT, the more likely you are to go straight from your 0 that you're going to have on ADT up to that level, and then you just level off. Is that sensible?
Yes. It's actually
Okay.
more complicated than that. I've tried to explain it, and I've actually put a graph up on the screen. I could try it again, but it's sort of hard. Let me just take a minute, a quick minute to see if I can show you this. Just bear with me.
While Rick is working on that, Doug, I could ask you if you ever got a cardiology opinion or a statin opinion.
Not yet.
Okay.
Well, I am going to start on statins, I'm sure, but I do want to see a cardiologist. I'm trying to get referred to one. because I have a very high cardiac calcium score, but I have really quite good lipid panel. So I doubt that just a straight statin is the solution, but I'll have to find out. I need to get in touch with a cardiologist to find out what the
Okay, I'll
appropriate.
just be curious whether they
Yeah.
how they call that one.
I'm more than curious.
Did you say you did get a PSMA scan in November?
I have not had one.
Has not had one. Okay, that's what I
I
thought.
can't.
Yeah.
I can't get a referral. On that subject, wouldn't an MR, since I did have an MRI prior to my biopsy and I had radiation, so my prostate is still there. Would an MRI now be valuable at determining whether or not there's any progression of the disease?
Your PSA still very low?
It went straight from 0 at end of ADT up to 0.7, 0.73, 0.75, and it's been there for the last 3 tests.
I think a PSMA PET scan might be a little more sensitive.
Right. My thought is that it may be a whole lot easier to get referred for an MRI.
Yeah.
So if I get a PSMA PET scan, the goal, the best use for it would be hoping it's not. Let's see. You don't want to see metastasis.
Right.
What you do want to see, you want it to find if there is any progression outside the prostate, I assume, and that would lead you to treatment.
You're on treatment though, right?
No, I'm not on treatment.
Oh, sorry. I thought you were still on Lupron.
No, that was over a little over 2 years ago.
Okay, I understand.
Easy.
So it's the recurrence I'm wondering about. And tonight you were mentioning the ctDNA and the CTC. Are those not used to check for recurrence?
Dan?
They are used, but they're used sparingly because normally we will see it with a PSMA scan or we'll see it with an FDG PET. The reason we were talking about it with Kang is because both of those came up negative and his PSA is already over 5.
Okay.
So it would not be an appropriate discussion for you. For you, the appropriate discussion would be, I need a PSMA, which is what we've been trying to get you, and trying to get you treatment. But for whatever reason, they're recalcitrant. They're recalcitrant it's slow at the VA, and Kaiser is being Kaiser, right?
Right.
My suggestion, one suggestion I had, but we didn't follow it through, was switch your Advantage plan, because you should not be at Kaiser. I may not be too late. You may be able to switch the Advantage plan after the year. I think you can. Talk to a broker. Do you have a broker?
No. I'm on Kaiser because my wife worked for Kaiser, and we've had that for many years, and it's free.
And good.
And good.
It's
well, the
not
VA
good.
would be free too.
Yes.
Say again?
And I have to disagree with your wife. It's not good. It's fine if you don't get sick. It's great if you don't get sick. But if you get sick and you have more advanced disease, it's horrible, because they manage your care and they don't manage it effectively. And I have the experience myself. So, when somebody says it's great, yeah, it's great if you don't get sick. And you can get multiple opinions and this, that, and the other. But look at Doug. We can't get him a PSMA test. He should have had it ages ago.
And this is why I'm going to the Veterans Administration.
That's right. We're tying ourselves, Mrs. Dufresne, we're tying ourselves into knots trying to get him a PSMA test. It's crazy. So that's why it's not good. Let me just show you this. You can see this graph that's on the screen now. Everybody can see it. So this is the graph of what we expect PSA to do after radiation. So your PSA starts up somewhere. It doesn't really matter what the number is. You pick a number, but let's just say before you had any radiation, your PSA was 10. And you have radiation and your PSA drops, and then there's a bump. And it goes up a little bit, and then it goes all the way down. And hopefully it goes down after 3 years or so to zero. So we all understand that. Now, if you get ADT, you immediately get forced down to zero because the ADT works and you don't have any PSA. So you move along this zero line. And let's just say you're doing 24 months, not 12 months. But say you're doing 24 months of hormone therapy. When you stop at that time, your PSA is going to increase right away, but it's going to increase to the level that it would have been if you had no PSA at all, if you had no ADT at all, no hormone therapy.
Right.
So it climbs up to this level around here, and then we expect it to drop along the same pattern that it would have done had you had no ADT. This is what happened to me. And this graph is courtesy of Dr. Stephen Frank at MD Anderson, who I sat next to at a meeting around 2014, 13. It was a Mike Millikan meeting. And I said, nobody's been able to explain this to me. And he took out a napkin and he drew this for me. And I redrew it onto a piece of paper, and I saved it. And I've actually talked to Dr. E about publishing this with her because there's no explanation. You can't find this in any of the journals, but this is really what happens. So a man who comes off ADT after 12 months or 18 months, if you came off after 18 months, Doug, you would be here and you would have been going up to like here. In my case, I went up from nothing. I went up to 1 in the space of about 11 months. And it kept going up and up. And I'd call Mac Roach up and say, Mac, it's going up. Oh, don't worry, it'll come down. Oh, don't worry, it'll come down. You know, for the first 6 months, I wasn't so worried. But when it didn't come down, I was a little worried. It got up to 0.96, I think. And it peaked at 0.96 and then it came down.
Right. So if you're on the line A coming off ADT, just for example, look at the 12 months. It looks like, well, when you're climbing, you can't tell whether you're climbing to that point where it's going to go down or whether you're actually having a real bump.
Correct.
So, right. Yeah, this chart is different from the one I found online because the one I found online just showed it kind of leveled out at like 0.8 or something. But
okay,
what you're saying is I should expect that it will end up going to zero eventually.
No, we don't know. Because if it's metastatic and it's gotten out the capsule, no. If it's not,
no, I mean, if the radiation was successful, it should just it should actually end up going down to undetectable.
Yes, but you've got to remember that back in 2009, we didn't have PSMA scans. Right. So why do we want your PSMA scan? Because we don't know. You did 18 months, correct? Isn't that what you said?
Yes.
So you would be somewhere, I can't draw it in, but you would be somewhere here, close to the B going up there, right? Now, if you were in that place right now, you should have a PSMA scan to make sure we don't see anything outside. That's how we control today. We couldn't control that way 15 years ago.
Right.
Right? And so, but hopefully that this graph helps you.
Yes. Yes. As you said, you can't, this isn't information you can find anyplace. I don't know didn't know what to expect.
That's right. Unless you come to AnCan.
That's right.
Right? I'll send you the graph tomorrow. I've made a note, and I'll send you this. You can have your own version of it and play around with it. But it's not. It's totally theoretical. There's no numbers. Don't assume any numbers. It isn't saying. That's why I put no numbers on the PSA. I deliberately put no numbers on the PSA on the y-axis.
Right. Okay. Understood. And you know, that confirms the one I found more or less. The one I found just shows, well, maybe it's going to level out, but
okay,
some
guys,
value
we got to keep moving. We got to keep moving. But that said, you have got to keep pushing hard to get that PSMA scan.
Thank you very much.
Graph to them, to Kaiser, and say, I want to know. I'm at this level. Okay.
Yep.
All right. Let me unshare my screen. Stop sharing. Okay, we're back to stop sharing. The next person up on the list is Richard Fisk.
Good evening. Just a quick update. I got a call from Dr. Jeff this afternoon, and we talked for a while. The last issue I had was difficulty coming off prednisone. And I talked my doctor into getting a cortisol test. The result was 12.3, which is right in the middle of the standard range. So evidently, the cortisol is functioning. I had started a longer taper of prednisone, and so I will be abbreviating that some, but still doing a taper. He also did a series of blood tests and found that my iron is screwed up, and that would also contribute to the symptoms I was having, the massive fatigue, blood pressure, and so on. So I think that I'm okay as far as coming off the hormone therapy, and now I've got to start wrestling with whatever's going on with the iron.
So I have a couple of questions, and then this goes over to Dr. Jeff. Are you feeling better since you added back a little prednisone?
Yes.
Okay. So that would tell me, who doesn't have any medical qualifications, that maybe if you are feeling a little better with a little bit of prednisone, that it probably did have something to withdrawing too quickly, notwithstanding your current cortisol level. That's what it would tell me. What did your doctor?
That's why I am continuing
Yeah.
with an extended taper.
And what did your doc say when you spoke to the doctor about coming off way too quickly?
He was amenable to, he didn't have any problem with my doing an extended taper. He did do the cortisol test along with a number of other tests. And he was happy with the cortisol result, which is right in the middle of the normal range. Right. But I'm still doing a more abbreviated but still extended.
Right. No, got it. Let me go over to Dr. Jeff. Dr. Jeff, this is your wheelhouse here, and you're muted right now.
Okay, what's the question?
Well, what do you make of this? If you remember,
I think Richard's doing fine.
Good.
You know, I think he can shorten his long taper. His cortisol is good. And his cortisol is good. His ACTH is good. And I think once he stops the prednisone, his adrenals will be working fine. It sounds like they're working fine now. Richard, though, this iron, you don't have iron deficiency anemia.
I have
You're
not been diagnosed, but my TIBC was 59, and the range is 250 to 400.
yeah. So what is your hematocrit?
38.8%. So that's just a little low.
Little down. Yeah. Yeah. So do they know why? Have they weren't you having bleeding at one time? Rectal bleeding or something like that?
Yes, I'm controlling that with sucralfate and stool softeners.
But maybe that's where you lost your iron.
That may be, but with the TIBC where it is, that could be also excess iron. I may have to get bled. So I just discovered those numbers this evening, so I've got to go to my regular doc, my primary, with these in hand and say, what do I do?
And I would just add, when you speak to your primary, if they're talking about bleeding you, they also should be controlling for polycythemia vera.
Well, the bleeding was just one of the many options that I ran across online, and so I just mentioned it.
Yeah, well, be careful of Dr. Google. You know, be very careful of Dr. Google. I thought it was your doctor that suggested the bleeding to you, but
no,
okay.
There's not going to be any bleeding.
No.
I recognize the Abraham Lincoln was also suspicious of what he found online.
What did he have under his hat, though?
A very tall haircut. Anyway, Dr. Jeff was very helpful in reviewing the bidding today and helping me sort out where I am, at least on the prostate cancer side of things. And this iron stuff is a whole different ballgame, different from prostate cancer, but at least some of the symptoms overlap. So that's worth looking into.
Okay, well, can I gather from that Dr. Jeff was helping you offline and giving you some navigation?
Absolutely. And he was not providing medical advice.
Okay.
We were merely discussing
No, of course not. But he's allowed to, because he's a practicing doctor and he's up to, so he could have done it. But what I do want to do is a big shout out to Dr. Jeff for stepping in and helping out here. Thank you so much.
Absolutely. Thank you very much, Doc.
Really appreciate it, Jeff. Really.
Don't let anybody bleed you with a crit of 38. Polycythemia, you don't have a crit of 38 with polycythemia.
Okay.
So don't go down that road right now.
Okay.
I've either got too much or too little iron. I'm not sure which.
I'll bet you have too little.
Okay. Iron filings. That's what I say.
Yes. Eating rust.
That's right. That's exactly that. I don't know if you can get norovirus from eating rust. I'm not sure. I hear it's going around. I'm getting way out of my depth here, Dr. Jeff. Okay. Anyone else want to say anything to Richard before we move on to Thomas? Okay. So next is Thomas.
Okay, here I am.
Good.
I've just got a fairly general, simple question. I'm just wondering, I'm on Firmagon and darolutamide. And, it's been 2023, I went on to the Firmagon, and I started Nubeqa in April of 2024. So I'm kind of cruising along. I'm doing okay. I don't have any big issues or anything. but I do have some symptoms, fatigue, small things like that. And one of them is some testicular pain. Um, and I've been to my urologist about it. He didn't seem to make too much of it. My self exam doesn't reveal any kind of a lump or bump or anything, but it does. I do have a kind of a tender spot. It's not enough to affect me much during the day. If I cross my legs the wrong way or this or that, I get a little hit of pain there, but it's not something that I'm too worried about. But my question is, since the ADT, I think it affects, I've always heard about, the genital, it could change the size of your testicles and your penis and do these physical changes there. Could some of that pain be due to the ADT that I'm on?
Who wants to take that one? That could be another one for Dr. Jeff. Dr. John just left. Oh, but Dr. Jack arrived. Oh, Norm Pollock's got his hand up. We'll start with Norm Pollock because he's got his hand up.
I had the same thing. My damn testicles ascended on that. That stuff kicked my ass. I'll tell you. I mean, I went from 755 testosterone to 0 in 3 months, and my testicles ascended. They weren't even there. And yeah, I got pain in my right testicle all the time if you pump it wrong. So,
that's where mine is on the right side also.
Yeah. Well, those damn cords are just sucking back up, pulling on them. It's like instead of somebody grabbing them and pulling them down, somebody's grabbing them and pulling them up.
Yeah. Dr. Jack.
Yeah, I have absolutely the same thing. I've got a lot of sensitivity, a lot of pain to touch, and of course shrinkage. And it's psychologically painful and physically painful to watch that process and to feel that process. hoping a respite from it all will come, and I'll be able to minimize that kind of pain.
Yeah, I'm kind of hanging in there with it myself, and I've been delaying going back to the urologist because I'm really not sure if he gets any kind of a connection with the ADT and this pain. I'm just not sure, but I think I will just hang in there and hopefully, because it's been a couple of months and it hasn't gotten worse. It hasn't really gone away. And so I thought I'd ask this question.
Okay,
and, go ahead.
I was just going to say, don't go away, Harry Spieler. We're getting to you to close out. What I would suggest to you, Thomas, is have you raise it with Dr. Sokolova? Have you raised it with Dr. Sokolova?
No, I have not done that with her.
Well,
when I mentioned that testicular pain, I think she said, if I recall correctly, that and I told her I was going to see a urologist. She says, well, we'll let the urologist handle that.
Okay. Well, I think you should discuss it with her, because if it's related to the ADT, then that's really part of what she knows, and it sort of falls between the urologist and the GU med-onc. But yes, I mean, I've heard of people having testicular pain from long-term ADT, and we got 2 guys in this group tonight who are going through that. And of course, everybody's different. We know everyone's different, so we don't know how it, it affects some, it doesn't affect the others. But I would definitely say, you're speaking to the uro, but what's her view and how often has she seen this type of testicular pain from longer term use, 12 to 18 months use of hormone therapy?
Okay. Yeah, and I had another question, but it's not an issue for me right now, and I know we're after the hour here, so I can bring that up at another time.
Please, if you don't mind, please hold on to it, and let's keep going here and get to Dr. John has left, so I don't know what his intriguing topic was, but I will find out. We'll have to wait till next week to see what he had in his mind to get us all going. So I'm going to move on to the last person in line tonight, who our friend in Chicago, Harry Spieler.
Hey, thanks for hanging on to let me ask my question. I feel a little silly now asking. It's going to sound crazy, but I had been seeing these commercials and ads for testosterone replacement, and I started reading about it. And it's a synthetic testosterone apparently, and so I thought, well, wow, I wonder if prostate cancer responds to synthetic testosterone as it does to your body's testosterone. So I started looking online to see if I could find information, and common sense obviously tells you it's probably not a good thing, but I really couldn't find anything that showed that anybody had looked at that or tried it until I came across some trial for, I think, castrate resistance, where they're using that on and off to kind of throw the cancer off. It was a small trial,
Yeah.
but as far as otherwise, I haven't found anything, and I'm going to see my oncologist tomorrow, and I just thought I would ask here if anyone's heard of that being tried or even discussed as far as, an option to try and offset some of the side effects from ADT.
Who wants to speak up on this? I thought I heard somebody wanting to come in. Len, go ahead, please.
Yeah, I certainly wouldn't recommend testosterone replacement unless you're pretty confident you're cured of your prostate cancer, Harry. I don't recall weren't you a Gleason 9?
Yeah, and I'm not thinking about doing it. I'm just surprised that there's nothing available where that was looked at in a medical, forum or of some sort. I mean, common sense says, yeah, it's probably not a good thing, but I was just curious if anyone has heard of any trials or anyone looked at that in the past. I mean, it just,
so
like I said, I don't know
think
if a synthetic testosterone reacts differently with cancer than your body's made testosterone. And I don't know if that was ever, reviewed or looked at in any literature.
So there are two hands up, and I'm going to go to both of them. But I just want to say, as far as I know, it has been looked up, and there has been, and there's quite a body of literature on testosterone replacement after prostate cancer. I mean, I know I've seen stuff, and I mean, I can look at it in my stuff, but there has been a lot of stuff, and the general wisdom. Certainly, if you're not metastatic, that it's on the table. What you saw in those BAT trials is something completely different, and it shouldn't be confused. But I think there's a bunch of literature now. When you're metastatic, I think it's really dicey, but I think there has been some stuff with testosterone replacement, and I wouldn't put synthetic in there. I would just put testosterone replacement for metastatic prostate cancer patients if I was searching. Luther and then Chuck. Luther, what can you add on this one?
I know if you're talking testosterone replacement, there's no real difference between that and your body's produced testosterone from a cancer perspective, if you're talking injections.
Okay.
Because I hear they made someone immediately stop when he got diagnosed with prostate cancer who was previously on testosterone replacement therapy.
Right. And the real question is, if you stabilized for several years, 3 years, 4 years, I don't know what the period is, would they allow you to do testosterone replacement therapy again?
Well, when I was starting treatment, they alluded that they would after some time.
Okay.
Because they, current thinking, again, not a doctor, but I'm familiar with this from Dr. Google, I guess, and talking to the people at OHSU. Their current thinking is in a, I guess in a pre-surgery or pre-treatment man, right? That it doesn't take high levels of testosterone to cause a response and growth, right? That's why they don't think high testosterone levels actually cause cancer. You need a level like 80, and that's as much as a
That's
tumor will
correct.
use.
Yeah,
If you're 1,000, it doesn't make it really go any
that's right.
faster.
Yeah, that's right.
And that's all I know from a layman's perspective. I think if you're cancer free for 5 years, they'll probably put you on it.
Chuck, what do you know?
Yeah, I think, are you talking about BAT, or is that something different?
No, we are talking about BAT, but BAT is not what this question is about. What I said
Oh.
is, as far as BAT is concerned, let's not confuse it with BAT. BAT is a completely different, yes, they give you testosterone, but it's a completely different ball game to what we're talking about.
Okay, I just wanted to mention I had a meeting with Samuel Denmead at Johns Hopkins.
Yeah.
To discuss, alternating high testosterone with ADT as a treatment. And it's supposed to help 1/3 of the men, but 1/3 of them, it makes it worse, and 1/3 of them doesn't help at all. So, but never mind. I thought you were talking about that.
No, I mean, BAT's a whole nother discussion, but my, my bottom line with BAT is that when it does work, it doesn't work for very long. It works for a few months for those who have very advanced disease, and it might get you a few months, but it doesn't work for that long. But we can talk about BAT another time. And by the way, we have a webinar with Dr. Denmead on our website that he did with us several years ago. So if you haven't seen it, you might want to watch that BAT. But BAT is not what Harry's talking about. Right, Harry?
Oh, yeah, correct.
Okay.
So
well, thanks much.
Here's what I would say, Harry. Don't be surprised, knowing your doc, that it gets thrown out of hand, but it might not. I may be 100% wrong, but I also have a feeling it might get thrown out, without discussion. I would be talking to the men's health doc at Northwestern. I think I think the urologist is Murphy.
Well, Rick, that's why I'm asking here first, because I know what might happen tomorrow. So
well, it might happen whether or not you get it. So
it's just informational right now. It's not something necessarily I'm thinking.
You might want to. I think from memory, who was it before that was telling me that somebody in the group tonight said they were with a urologist, but it was the sexual health urologist. I can't remember. Oh, Don Rogers. But you might want to discuss it with whoever the sexual health urologist is at Northwestern. I think it might be Adam Murphy.
You gave me the name. I don't know if that's it, but I have it.
And see what they say. And if they think it might be a good idea, you say, well, could the three of us have a discussion with Dr. H? And then we could Dr. H and you and me all talk together? And that way, if she does throw it out of hand, you have Murphy in your court. And if she doesn't have it, throw it out of hand, you got the man who's going to be involved, Dr. Murphy. So it's like a no loss for you. But I'm concerned that if you say to her and she does throw it out of her hand, and then you say, well, could I talk to the Euro? She's going to say no.
Yeah, I try to do my homework before I bring things up with her. So
yes.
I appreciate feedback.
Understood. All right. Well, we've gotten around everybody, I think. Anybody else have any questions before we close out?
Rick, am I up next or is it Ben?
Ben,
Okay.
you are the third week. You promised me
Yes,
you
sir.
put it in your calendar. You're
I did.
the third Monday. You are up on the 20th.
20th, right, okay.
Unless you want to switch. In which case, let us know, and then we'll all arrange a switcheroo for you.
No, I'm fine.
Okay. Anybody else have any questions before we call it a night? Check out that. Oh, Jack. Jack. Dr. Jack.
Yes, sir.
You came in late, so you didn't see this. So let me put this in here. I'm gonna put something in again for you in the chat window. And Dr. John is supposed to be letting you know, but he said I could say it today. We found out on Friday that they published our letter in JAMA.
Oh, great.
And guess who the #1 author is on that letter, Dr. Jack?
Dr. John.
No. The #1 author is Dr. Jack.
Oh, you put it in order of age.
We put it in the order of who responded and who took the time to do the initial heavy listing. That's heavy lifting. And Dr. Jack came back with a draft, first of all, which Dr. John used, and there was more. So the first doctor on that list is Dr. Jack. We did send it out to all our docs. Some of our docs responded and said they wanted to be on the letter, and others did not. So those who said they wanted to be on the letter are the ones who are on the letter, because I don't want to offend Dr. Jeff here. But check that letter, check that link that I just put in, and click on comment at the top, and you will find Dr. Jack Baruch et al. Got a letter printed in JAMA.
Well, thank you. I appreciate you putting me there, and I enjoy doing it.
Thank you very much. And a big shout out to Dr. John, who's left, but we gave him a shout out at the beginning of the meeting, but you can send him a note too.
Okay, I will.
All right.
I'll look at it now. Thank you.
We're back next week, and I hope our newbies, Gary and Wes, I don't know if Wes is still with us, he's probably left, but Gary, come back next week and give us an update. All right?
Happy
Good night,
12th, everybody.
Good night, good night.
Thank you, Rick. Thank you, Dr. John. Very good. Bye-bye.
Thanks all.
Right.